neurointerventional case.
Good evening, everyone. I'm Minatallah and today I'll be presenting two interesting neurointerventional cases. This session will be an interactive one through which I'll be asking you multiple questions regarding each case. Starting off with our first case, we have a 10-year-old boy presenting with vomiting and right-sided hemiparesis of few hours duration. His NIH score was 11. The first thing that comes to our mind are these four differential diagnoses, which are migraine, seizures, DKA, or stroke. To narrow our differentials, CT brain was done, so let's have a look together and try to spot any abnormalities. So what do you think of this CT brain? Is it suggestive of any of these findings, or is it a normal study? Okay, as it's evident, this is an unremarkable study. In such cases, our next step will be ordering urgent MRI brain stroke protocol. In these cuts, we can see the three common sequences, T2, flare, and ADC. Please have a look and try to spot any abnormalities. What do you think does this MRI reveal? T2 shine through in the MCA territory, temporal lobe abscess, through restriction in MCA territory, or meningitis? Anyone? Excellent. As we can see here, there are two sizable areas of true diffusion restriction involving the left basal ganglia as well as the nearby temporal lobe, exhibiting faint hyperintense signal in the T2 and flare sequences, which is suggestive of acute non-hemorrhagic infarction. MRE was also done. What do you think does it show? Occluded right ACA, occluded left MCA, ICA terminus occlusion, or occluded right PCA? Okay. It reveals occluded left MCA with proximal interluminal thrombus, as well as mild to moderate focal stenosis in the ICA between the cervical and pitreus segments. So finally, we reached a solid diagnosis. This boy suffered hyperacute stroke, left MCA occlusion. Accordingly, mechanical thrombectomy using a stent retriever device was urgently done. Here are the before and after angiography images showing complete recolonization of the left MCA. Now, although this patient presented late to the ER, almost 24 hours after the onset, yet new studies suggest that according to MRI images, by assessing flare diffusion mismatch, the patient can be subjected to extended windows of thrombectomy, especially in young age groups. Usually after patient's intervention, multiple scoring systems can be used to determine its success. Most importantly, the TICI score, which is a tool determining the response to thrombolytic therapy after ischemic strokes. And in this case, the TICI score was 3, which indicates complete perfusion. We also use the MRS, which is a scale of functional outcome in individuals who suffer neurological insults. And in this case, the scale was 0, which indicates 0 disability. Also, this patient's NIH score was back to 0, and all these scores mentioned are 12 hours post-thrombectomy. Now, moving on to our second case, we have a 39-year-old male patient presenting with severe right-sided headache associated with right-sided pulsatile exophthalmos after a road traffic accident. CT brain was done, and this is the imaging. What do you think of this CT brain? Is it suggestive of dilated superior ophthalmic vein, subarachnoid hemorrhage, normal study, or orbital pseudotumor? Anyone? Okay, as you can see, there's dilated right-sided superior ophthalmic vein with ipsilateral cavernous sinus enlargement. Diagnostic angiography was done right after. Please take a look. What do you think does it reveal? Dural arteriovenous fistula, direct carotid cavernous fistula, AVM, or aneurysm? Excellent. As you can see here, that upon transarterial injection through the right ICA, filling of the cavernous sinus was noted during the arterial phase, which indicates the presence of a carotid cavernous fistula. Now, these are the signs that trace the possibility of a carotid cavernous fistula in any CT brain. They include orbital congestion in the form of proptosis and enlargement of extraocular muscles, venous engorgement in the form of enlarged superior ophthalmic vein, and bulging cavernous sinus. So what is a carotid cavernous fistula? A carotid cavernous fistula is an abnormal communication between the carotid circulation and the cavernous sinus. It is usually classified according to various features. However, most importantly, it's divided into two main types, which are the direct, which is a direct communication between the intracavernous ICA and the cavernous sinus, and indirect, in which the communication exists via branches of either the external or internal carotid artery. It usually presents with pulsatile exophthalmos, chemosis, proptosis, progressive visual loss, pulsatile tinnitus, raised intracranial pressure, subarachnoid hemorrhage, or cranial nerve pulses. We have multiple treatment options, which include conservative, carotid compression therapy, endovascular, or surgical. In our case, endovascular treatment was the treatment of choice. Transarterial balloon-assisted coiling was done, and here are the before and after angiographic images showing complete closure of the carotid cavernous fistula, as well as the restoration of the ICA appearance, with this appearance of the cavernous sinus early filling. This patient was discharged 48 hours after the intervention with improvement of all his symptoms, including the proptosis. Thank you.
شكرا دكتور.